Here we present the arthroscopic technique for removal of an acetabular rim-based osteoid osteoma and concomitant FAI correction in a 16-year-old male with a 5-month history of atraumatic left hip pain. Radiographs reveal a cam deformity identified by the yellow arrow and a rim-based acetabular osteoid osteoma and mild lateral overcoverage identified by the white arrow. Preoperative CT scan better localizes the osteoid osteoma to the acetabular rim and defines impingement anatomy. After gaining access to the hip joint, an interportal capsulotomy extending from the mid-anterior to the anterior lateral portal is performed with a banana blade. The anterior lateral portal is used as the viewing portal while the mid-anterior is the working portal in the initial part of the procedure. A complete diagnostic evaluation of the hip joint is performed, including evaluation of the labrum, articular cartilage, and the lunate fossa. Bruising of the labrum secondary to impingement is identified in the lateral labrum with some labral chondral disruption anteriorly. A shaver and a blade are used to expose the acetabular rim in preparation for rim decortication using a 5.5 mm motorized burr. The acetabular rim lesion is readily identified after rim removal to the predetermined depth as determined on CT evaluation. In this case, 4 to 5 mm of resection exposes the lesion, and the surgeon must remain vigilant to avoid inadvertent cartilage destruction. Here the lesion demonstrates punctate hyperemic fibrous tissue typical of an osteoid osteoma. A rim resection has been completed on our approach to the lesion. A ring curette is used to precisely excise the lesion. We continue the resection until we are able to observe normal cancellous bone circumferentially around the initial lesion location. Finally, a thermal device is used to ablate the lesion, again being mindful of the proximity to articular cartilage. After adequate lesion removal, AIIS decompression, and rim resection, the labrum is repaired using PEEK suture anchors. Sutures are passed in a mattress fashion with a suture passer. Appropriate suture and anchor placement avoids eversion of the labrum, with anchors placed in the 10, 11, 12, and 1 o'clock positions. Traction is released and the peripheral compartment is assessed in order to evaluate the femoral cam lesion. A large femoral lesion is seen here, now viewing from the mid-anterior portal and working through the anterior lateral portal. The femoral osteoplasty is performed with a motorized 5.5 mm burr. The lesion is addressed from the medial to lateral synovial folds with careful attention paid to avoid the vessels. Dynamic evaluation subsequently shows appropriate cam resection and resolution of the area of conflict. After FAI correction, the hip is exsanguinated of all fluid and bony debris. A capsular repair is completed with 3 to 5 number 2 non-absorbable sutures placed in a side-to-side fashion utilizing a suture shuttle technique. Post-op radiographs reveal rim resection with removal of the osteoid osteoma and appropriate femoral resection. Post-operatively, the patient is pain-free and has returned to all pre-symptom activities at most recent follow-up. Outcome measures are significantly improved post-operatively.